Hey, NAMI students, Mr. Yance again. Hey, day two of notes. We're going to go over the parts of the knee. I talked about this the first day of notes. We're going to use the knee as our representative for joints. We could use the shoulder, the elbow, other joints of the body, but the knees being the most complex one. We're going to use it as our example. So let's go over the parts today, and then I'll go over some injuries and how we fix those parts later. Meniscus is mainly cartilage. It's fiber in a firm gel, has a little flexibility to it. Think of insoles in a shoe, uh, and that's basically what they are. The femur comes down top of the tibia. These are in the space between. And it just keeps the tibia and femur from coming in contact with each other. The medial's on the inside, the lateral's on the outside, and both of them do the same thing. They just help cushion our knees so when we jump and run and turn and twist. That takes all the abuse and keeps us from having those bones grind on one another. So they attach on the flat top of the tibia, and you can see them. Let me show you a picture on this next slide. You can see them right here. They basically are just keeping. Here's my femur. There's my tibia. The tibia is really flat on top. Just keeps it from hitting. Okay, and just like a insole in a shoe gets out of whack, and causes, let's say you have insoles in your shoe and you put them in the wrong shoe, you're going to feel that discomfort. And that's what happens when people get little frays in them. About 8 years ago, 9 years ago, I had that fixed. I had a fray in one. They went in there and fixed that. So, pretty common injury, pretty easy fix. Took 10 minutes, I think, to fix it. So, a lot of people have that problem. And it's just wear and tear and injuries and things like that. So, that's called the meniscus. The main part of the knee, though, is the ligaments, and that's what I want to spend the most time on is these first two, the ACL and PCL. Since the knee doesn't have all the muscling around it like your shoulder and elbow and stuff like that have, these are what hold your knee together. And when you hear severe injuries, I talked about this on the first day of notes, season-ending injuries in athletes, a lot of times it's the ACL, okay? Kind of interesting how they work. The ACL, they're basically named after where they attach on the front side. So the ACL attached to the front part of the tibia, the anterior side. It goes between the condyles. The condyles are rounded projections. There's a little tunnel between them on the femur. It goes through there and does an interesting thing. It turns over and goes backwards and attaches to the opposite side, the posterior side of the lateral condyle of the femur. The posterior cruciate's the opposite. It actually attaches on the front side of the medial condyle of the femur. It crosses over and turns over backwards as well, and attaches to the posterior part of the tibia. So you got one on each side of the femur and one on each side of the tibia. Now here's what's important about the posterior and anterior cruciate ligaments. They're like Y's, and if you take your two fingers and put those together, they're pretty strong. But then if you twist them, it gives you even more strength, and that's what they do. They come together and they twist by turning over backwards, and that's what gives you that strength, and that's what keeps your tibia and femur lined up on top of each other. Sometimes you'll see an athlete go down in the athletic field, an athletic trainer or doctor runs out there. It looks like they're being very cruel. They actually grab the lower leg and move it. They're trying to see if there's instability there, and that tells them a lot of times that these ligaments are injured. They call that a drawer's test, like opening and closing a drawer, and they're just trying to see if there's any play in there. There shouldn't be. Those are very, very important ligaments. You see, I have a little asterisk beside the ACL. That's what holds your knee together, basically. All right. Ligament Risberg, you don't hear much about it, but it also is kind of like an accessory. It's kind of behind the posterior cruciate, and it does it's just a helper. It's not the main ligaments like the ACL and PCL, but it does help keep that knee stable. Okay. Now we also have a transverse ligament, a lot of ligaments in the knee that keeps your meniscus from sliding. Remember, we talked about the insoles in a shoe. That's what's going to keep those from moving. You don't hear about it getting injured much. It's just basically there to help keep those meniscus from moving one side or the other. The outside of your knees have a tibial and fibular collaterals, also called the medial and lateral collaterals. There are super strong ligaments on the sides of your knee, and they're giving you stability left and right. ACL, PCL keeps you stable frontwards and backwards. These keep you stable side to side. A lot of times they get strained and torn, and people have some problems with those too. So those are the main ligaments: ACL, PCL, ligament of Risberg, transverse, and then the tibial and fibular collaterals. And that's basically what's holding your knee together. So when these get torn, then you got to go in and through surgery get those fixed. Okay. Um, Now the bursa, they are not ligaments, they are not cartilage, they are fluid-filled sacs. They kind of pad your knee. You have 4 in the front, 4 on the lateral side, and 5 on the medial for a total of 13. A baker's dozen, we call that. It seems like that's backwards. It seems like we should have more on the outside because we get hit on the outside of the knee more, but that's not what they are. You can see from the picture sometimes they get inflamed. This is called the prepapitellar. That's the biggest one in front of the kneecap, and that's an inflammum where someone hit their knee really hard on a hard surface, and it causes it to inflame and cause problems. Okay. Um, the thing with the bursa is sometimes when they get injured, it looks like a really serious injury. Your knee puffs way out, looks like a water balloon burst. But usually they heal on their own and usually don't require surgery. So you got to kind of be careful. Looks are deceiving. Sometimes people have a serious, they think it's a serious injury and it's not, and vice versa. Sometimes these ACL and PCLs are torn and people don't think it's a big deal. It's very hard. That's why it's very important to have all these different tests and MRIs and diagnostic capabilities in the hospital to say, hey, this is the problem. Here's how we're going to fix it. All right. Okay, I just want to introduce this next thing, and then maybe tomorrow I'll go over. I'll show you some videos of some knee surgeries and show you how this works. Let's talk about the arthroscope just for a second. So before 1970, the only way we could visualize a knee joint was to basically make this big, huge C cut in the side of it and open it up and look inside. Even minor surgeries, we had to do that major thing. The rule of thumb in surgery is the larger the incision, the longer it takes for recovery. So we want to try to keep these incisions very, very tiny. And we didn't have that capability before 1970. I remember my wife, she hurt her knee in late 70s, and they had to do a big extensive surgery. Today they wouldn't do that. So the arthroscope changed that whole surgery on the knee, made it much, much better. Basically, they make just 3 incisions, really tiny. We call them ports, and they have these micro surgical instruments they can insert and do even major knee surgery this way now. And really, arthroscopic surgery came about because of the fiber optic telephone companies invented this, and then they moved it into the medical field. Before 1970, all we had was these lights. We had cameras and lights we could put inside, but they were really hot. And fiber optics is really, really tiny. And not only is it tiny, it's a cool light, which makes it even better. Let me show you a picture. You can see a bee looking inside a fiber optic cable. It's how tiny it is. So they're making 3 incisions. And this is my knee. You can see the ports, pretty tiny ports. And that's what makes recovery so much faster. So they make these 3 incisions. In one incision, they put a small tube with the fiber optic lens and the cool light, and that's going to be linked to a monitor that the physician will look at. So when we watch a knee surgery video, you'll see a circle of light. That's basically the fiber optic cable. The second incision, they pump in saline. What that does is that makes the knee joint bigger so they can see, and they actually bend the knee, so it gives them more space in there. And that saline you'll see it looks like a river flowing through there when you watch a knee surgery video. Okay. And then the third port is the most important one because that's your microsurgical. The instruments look big when you watch a video, but in reality, they're not really that big. They're just magnified because of the saline and the camera. Okay. Now, when they say pain is minimal, I'm not going to say it's going to be pain free. It's not going to be sore, and rehab's going to take a while, especially if you have an ACL or PCL fixed. But when we say pain is minimal, it just means that recovery time is going to be a whole lot faster. And I think that's very important that we understand that. And the e-learning that I gave you for Friday, you saw a hip replacement. That's a whole different surgery because you have to open up the joint to get in there and get the joints out, the old damaged parts out and the new ones in. This is a lot different. For knee injuries, we can fix meniscus. We can do major repair and reconstruction. We can shave off patellas. We can make articular cartilage smooth again. And that's something that loose bodies, we can suck out of there like a vacuum. That's called joint mice. So it's pretty amazing what we can do. So let me show you a video. I know you'll hear an echo here. Might want to turn the volume down a little bit, but this is what arthroscopic surgery looks like. Okay, if I can get this to play, maybe not. We'll see.
I'm Dr. Eric Jansen, Sports Med Orthopedic Surgery and Spine Center. This video is an ACL reconstruction with a hamstring graft. The patient's a 15-year-old softball player. They tore her ACL while sliding into second base. She presented to our office with pain, swelling, and stiffness. Preoperatively, we go over the procedure with the patient. Here you can see us getting the patient's leg ready with the tourniquet, which we used during the procedure.
You'll see they'll bend the leg at a 45-degree angle. See how unstable that knee is?
First, we harvest the graft when we know the knee is stable. A small incision is made directly over the pes anserine tendons, and both the semitendinosus and gracilis tendons are harvested. Here you can see a loop stitch placed on one of the two tendons as we get ready to harvest it. A tendon stripper is then used to remove the tendon from its muscular bed and pulled out from the knee. After both of the two tendons are removed, we place our arthroscopic portals around the knee with a little small stab incision for each. The fluid we placed in the top portal is seen here, and the scope and working portals are on the front of the knee, just below the patella. Here you can see the arthroscopic camera setup where we watch the video.
So you can see it, you get a circle light, that's from the cable.
The torn anterior cruciate ligament can be seen here, no longer attached to the upper bone of the femur, and a shaver is used to remove the tissue from the old ligament, which is scarred against the posterior cruciate ligament that you can see behind it. We're also removing the old stump site on the upper bone in the notch of the femur. On the back table, while we're doing the arthroscopic portion of the procedure, the hamstring tendons are prepared by one of our assistants.
They're making a new ACL with a hamstring tendon.
The portal was made on the inner aspect of the knee, just above the medial meniscus as seen here. An initial drill pin is placed for our tunnel placement into the femur. A small reamer is then placed over top with a measuring device where we can read the depth of the tunnel, which will be important to our placement of our graft. We then clean the tissue off from around the initial tunnel site. Once again, a measuring device is used so that we know the depth of this tunnel. And the final reamer, once we know our graft size, is used to make the appropriate size hole in terms of the diameter and the depth is read off of this reamer. Once again, we clean away bony debris and soft tissue. We then will create the tunnel for the lower bone of the tibia, which the graft will be placed in. Here you can see the guide with the guide pin coming inside the knee. Once the guide is removed, a reamer will be placed over the guide pin until it enters the knee, once again creating the lower tunnel. Bony debris and soft tissue will remove in from around this tunnel. Next, a wire is then placed with suture attached to the upper tunnel and then brought down to the lower tunnel. This suture is then placed on the graft and pulled up through the knee to pull the graft in place. Here you can see the graft placed into the lower tunnel as we pull the graft into the knee. And while we're pulling into the tunnel, we'll help coax it up there with this nerve hook. The graft has been marked with ink so we know when the appropriate distance will be to get the graft in. And this will be confirmed with x-ray during the surgical procedure. After the graft has been placed, we cycle the knee to make the graft as tight as possible. It has already been fixed on the femoral side once it's pulled through, and now a screw will be placed inside the knee. It is called a retro screw that will be placed down in the tibia. Here the screw is in position. The screwdriver is placed into the screw itself. and then screwed down into the tibial tunnel, tightening the graft into the tunnel and holding it stable, or it then will be able to heal. Once the screw is then placed down flush, we will test the knee through range of motion and also retest the stability.
Okay, so that's basically, now I know I probably did this a little bit backwards. So let me kind of give you a little idea of what they just did so that you have maybe a little better idea. So when you put this, so that is a major reconstruction. So what they did, as you can see from this picture, is they literally take the ACL out and they took the hamstring one off out of the person, wound it together, made it strong. So it's going to take the place. And they literally drilled a hole through the tibia at an angle up through the femur. And you saw them do that. And then they literally hoist that hamstring ligament up through, or a cadaver ligament can be used as well. And they literally hoist that up through there. They screw it on this end. They cut it off and screw it on this end. And now we have a new ligament, and it takes time for that to heal and that person to make that strong again. And eventually they'll be right back in action. So that's how they do a major knee surgery, using the arthroscope, using these 3 little tiny ports in this cable called the fiber optic. Pretty crazy stuff. So I hope that makes sense. We'll talk about the replacement surgery you watched for e-learning, and we'll do that next set of notes. So, hey, thanks for watching. We'll talk to you later. See ya. Bye.